Cuando quieras, Alfredo.
Buenas noches a todos. Bienvenidos a este nuevo webinar de la Sociedad Española de Inflamación Ocular, que completa o seguimos todo el programa de formación que iniciamos durante este periodo, en el cual la parte online, la parte formativa virtual, pues tiene un papel relevante. Entonces, este webinar tenemos el placer de tener con nosotros a un invitado muy especial, que es el doctor Carlos Pavesio. Carlos es una persona reconocida internacionalmente en el área de las enfermedades inmunes del ojo, porque no solo uveitis, sino es un experto en otras patologías como la escleritis, como patología inflamatoria también de la córnea, y él es el coordinador, el director de la unidad de enfermedades inmunes oculares en un centro de alto prestigio en el mundo como es Moorfields Institute. Y para nosotros es un placer. Thank you very much, Carlos, to participate in our webinar. It's a pleasure for us that you be here with us and to discuss a clinical case first. El segundo caso lo discutirá Alex Fonollosa, que todos lo conocéis. Es miembro de la Junta de la Sociedad Española de Inflamación Ocular y también un experto en uveitis. And if we have enough time, we can discuss a second case, Carlos, but it depends of the time. But for me, you can start your case. Thank you very much to come to participate here.
Muchas gracias, Alfredo. Muchas gracias, Alex, por la invitación. Es un placer muy grande. Yo voy a hablar en inglés porque lo decía que mi español no es bueno suficiente para una charla, pero vamos en inglés, que es mejor para todos, yo creo. Ok, vamos. Okay, so I will present one case initially, and depending on the time, we can go on to present another case. I just want to acknowledge Dr. Ilaria Testi, who is our uveitis fellow at Moorfields, who helped me putting these presentations together. The first case, let me just start here. I'm sure my computer needs to kick in here. Let me just see if I can get it to work. Sorry about this. A small technical glitch here. Let me just see if I can. Let me just go for, sorry about this. I will share again. Okie dokie, let me just go for this now. Apologies for this delay. Let's see if I can get this to work. Okay. Okay, so the first case is this 56-year-old gentleman who is originally from India and had been living in the UK for about 8 years now. And he presented to us with a very severe reduction in vision in one of his eyes, his right eye, and gave us no history of any ocular problems before. He had mentioned in his medical history that he had lost significant weight, 21 kilos in 4 months, but did not complain of anything else. His examination showed that the vision in the right eye was markedly reduced to counting fingers, while it was normal in his left eye. He had normal intraocular pressures and just mild anterior chamber inflammation in the affected eye, with no signs of having severe inflammation anteriorly. This is what we saw in the fundus examination. So the eye affected, the right eye, had this lesion, which I will show you in more detail now. So it is a lesion which looks subretinal, is yellowish lesion and surrounded by fluid, and a disc that looks hyperemic and also slightly swollen. So looking at the OCT, we can see here that the area affected, as you can see here, looks like this homogeneous hyperreflective area, very typical of granulomas in the choroid. And we can see here this contact sign with the presence of subretinal fluid and even some degree of intraretinal fluid just above the affected area. The angiogram is showing this is not a very early shot. This is a bit later already, because the very early shot, you're expecting more of a hypofluorescence in this lesion. But as time goes, we can see an increase in the hyperfluorescence here and some early areas of hypoperfusion in the choroid, which disappear a bit later on. And the ICG angiography, which shows this area corresponding to this exclusion of the dye, so is a space-occupying lesion, and surrounded by fluid, which you can appreciate here on this later frame of the ICG angiography. So we, of course, decided to investigate to make sure that we were not missing anything. So we had a general test run, and of course, tests were targeting our suspicion. So we requested a quantiferon gold test for TB. We requested the ACE and chest X-ray, and also investigated for other potential infectious processes. In view of the location of the vision and the severity of the visual loss, I opted for starting steroids straight away, and we can discuss that later on, but I gave him 70 milligrams, which is very much 1 milligram per kilogram of weight. And then I felt on my clinical assessment, this is more likely to be TB. So my presentation is not about the diagnosis, which I believe most of you already have in mind, but will be the complexities of the management of this case. So the results showed that he was quantiferon positive. We had an elevated ACE, which can happen in TB, sarcoid, and other granulomatous processes. But he also had a chest CT, which showed that he did have pulmonary involvement as well. The other tests came back negative. So at that stage, he was on the prednisolone, and the specific treatment for TB was added. So this happened very quickly. This was all happening within 1 week. So we can see here, this is the presentation baseline on your left. And here we can see on the right, this is a week later, that has been a certain response. But this response is totally connected to the effect of the steroid. We can see some hard exudates accumulating in the macular region, which is reflecting fluid, the reducing and leaving the protein and lipids behind. And there's some degree of the reduction of the overall size of the lesion. This is the appearance of the OCT that I showed you before, the one at the top, the original one, and a week later, clearly a reduction in the amount of fluid. This is all, again, steroid related. So I have here this, why is this guy here questioning this? Because I saw 12th of May is when he looked a bit better because of the steroid, but then he comes back on the 26th of May when the lesion looks larger. And then we see him again on the 30th of June, when clearly he was getting worse. So what was happening here? So he was on specific TB treatment, he was on steroids, and he wasn't really responding very well. So the things that come to mind when you're failing to achieve your objective in a treatment of any pathology is that either you got the wrong diagnosis, so we're treating the wrong thing, or you got the right diagnosis, but you're not giving enough medication. And in the case of this patient, the question would be, is this a TB that is resistant to the treatment that he was given? Or the other element of the treatment would be the steroid. Was he not receiving enough steroid? I think you all remember that once we start people on rifampicin, which is one of the standard drugs in the treatment of TB, we are metabolically reducing the steroid element by 50%. So if we don't correct the steroid dose, if we don't increase the steroid dose, we're actually halving the amount of steroid we give them. So the other possibility is that this is truly inflammatory, and what I'm seeing here is reflecting poor control of the inflammation. The other possibility, the third possibility in failure, is the patient, you're doing everything right. It's the right diagnosis, you're giving the right amount, but the patient is not taking the medication. So compliance is a big issue here. So we spoke to the chest physicians, and they made some adjustments to his anti-TB therapy with the introduction of moxifloxacin to the treatment, and we also increased his prednisolone to 120 milligrams to compensate for the rifampicin in his treatment. So this is just to show an important aspect of his care. So we had the chest CT showing that he did have areas of activity which reduced after 2 months of TB treatment. And we also had the fact that this guy started to complain of headaches. And then he had an MRI scan of his brain with and without contrast showing the presence of an intracranial tuberculoma. So he had diffuse disease. He had also disease involving lymphadenopathy in the pelvic region, but he was responding. So according to the physicians, he was getting better. So his brain, his chest, everything else was getting better apart from his eyes. So that was a real problem then, because we are eliminating our first option, that is resistance of the bug to the drugs that I was giving. So what else could we do? So what we see here, 23rd of July, he had a still large lesion. In August, the lesion is different. He's getting some degree of retinal involvement now with a hemorrhage. And this is in spite of being on 3 months of anti-TB therapy and high dose of steroids. So at this stage here, we decided to do something different. And this is where we introduced a new element, which some of you may be aware of. We decided to give him an intravitro injection of Avastin. So Avastin is not licensed for anything, as you know, but it is easy to get hold of. And we decided to give him Avastin. And what we observed within 2 weeks of the injection, so this actually, I can't bring you the most up-to-date because this image is from last week. So this is 3rd of September, 2 weeks after the anti-VEGF, showing good response to that approach. So you can see here the image of the OCT showing that the fluid also being affected by the use of the anti-VEGF approach. Again, images comparing pre and post anti-VEGF. Again, one more example here. So this is just to show you this is not our idea. It's not original. It's been already published by other colleagues. And this is exactly showing that there might be an expression of VEGF in these cases of mycobacterium infection, and blocking the VEGF may have a positive effect in the management of these patients. And there were a few other patients which were directly reporting on the benefit of this strategy in the granulomas that were given different strategies. We have a bevacizumab, we have the use of ranibizumab. So it shows that the addition of anti-VEGF therapy may be a good way of dealing with granulomas which are not responding as you expect. And we might speculate why. Maybe he's getting enough medication into the eye, it may be different from the other tissues, so we have more resistance to the treatment due to that fact, rather than the bug itself being resistant to the drugs that you are using. So I just wanted to present this case because it is uncommon that we come across these situations, but you can see clearly this is an aggressive granuloma that failed to respond to high-dose steroids and to the specific treatment, or was responding very slowly. And with the addition of anti-VEGF, we're getting a better result. So probably when I see him again, which is next week, we'll have hopefully even more improvement than what we've seen so far. So Alfredo, I'll stop here for this first case. We can open for questions. And if we have time, I can go into the second one. So I hand over to you, Alfredo.
Thank you very much, Carlos. A very nice case. I think I have one question for you. In the first OCT that you show,
Yes.
I have, as you mentioned, there is a fluid, intraretinal fluid.
Yes.
And probably there is this is a bacillary retinal detachment because there is a fluid intraretinal split of the retina.
Yes, you're right here. Yeah, right there. Yes.
So in those cases, probably it means that there is a lot of inflammation.
Yes, I think this is what's happening here is we have two elements here. One is really a decompensation of the retinal pigment epithelium, which is allowing a lot of fluid through to the subretinal space. But I think when you have a lot of inflammation and the amount of fluid is increasing very rapidly, you can also have, in view of all the changes induced by inflammation, the presence of intraretinal fluid. And that's something that is sometimes it looks even like a small schisis because it can be a very large area. Yeah, it's something that I've seen some recent images of VKH cases in which that happens.
Yes.
And it really is impressive because it looks like a large pocket of fluid in the middle of the retina, not only the subretinal fluid, but the intraretinal fluid associated with very intense inflammation. You're right about that.
Okay. And what is your plan about the anti-TB treatment, systemic treatment? For how long are you planning to treat the patient and to maintain the steroids for the patient?
Right. So what we normally do, the steroid will be reduced according to his clinical response. So we will wait to see how he responds. Of course, now we have to wait to see how much better he'll get with this Avastin injection to decide if we need to even repeat that eventually. But it'll be important to see the response to the first one. The steroids will be gradually tapered according to the clinical response. The anti-TB therapy will be maintained for 9 to 12 months. So whenever we have eye involvement, we do prolong the treatment. We don't think 6 months is enough. He certainly needs at least 6 months because of all the other involvement, but the eye itself will require a longer treatment.
Alfredo, Carlos.
Yes.
Two comments on TB, ocular TB.
Yeah.
I think that there are two situations that are a bit difficult to manage. One is the paradoxical response.
Sure.
We sometimes see, and you don't know if it's really a paradoxical response or perhaps it's more the infection, the inflammation, difficult to manage. And then the other thing is that when you are treating these patients, you finish the 9-month treatment usually, then inflammation continues. I mean, you do the treatment right, you do the 4 drugs, 9 months, and then inflammation continues. And we have some cases that even we have put on anti-TNF to control the inflammation after the right period of time of anti-TB.
Yeah.
You have this.
That's an important point, Alex. It's important because I think in this case, I was less worried about the paradoxical response because I started with a very high dose of steroids from the beginning. And so I was in a way dealing with any of that already by doing this. But many times if we start the TB treatment alone without steroids, it's really possible that you see an increase in inflammation because of that, because of this, and many cases have been reported. I remember that actually was Marta Ugarte, one of our former fellows, now a consultant colleague in Manchester, who highlighted that to me years ago. I was so used to giving steroids as at the very beginning of my cases that I really very seldom see any inflammation developing as a paradoxical response. And I was a bit skeptical about it, but clearly, as soon as you start looking carefully, yes, of course it happens. And it is an important element to consider because, as you said, sometimes you have to escalate your anti-inflammatory therapy to the point of using an anti-TNF approach, which in general terms, you're trying to avoid in TB. But once you have the TB treatment on board long enough, then it's safe to do that. And yes, I've seen that too. I have to do that as well.
Okay.
Very good point.
And also it's very, I think is very important to know that the different response to the brain lesions, the brain granulomas and the thoracic granulomas, the pulmonary granulomas are different from the evolution of the eye, no? In this case.
Yeah, I think
surprising, no?
He responded well from the point of view of his chest and even the brain. I think he's responded well. The eye was the only thing that was really misbehaving here. So we were left with this situation of trying to understand why this was happening. And I think what Alex said, in terms, could it be a paradoxical response? But the true inflammatory events that we saw were actually reducing. It was just the bulk of the lesion wasn't getting better. The true granuloma wasn't getting better. So I think there might be something about the way the disease behaves that we still don't understand very well. And it's interesting, fascinating to see that an anti-VEGF approach can induce such a dramatic response. So it's just an interesting option as a strategy in cases that are really struggling. You're slowing down the recovery.
Okay, Carlos, a very interesting case, very nice picture. It was a very impressive, the evolution of the eye and I think this possibility to treat with anti-VEGF. I think we have a question. Esther Carreño, she sent a question about, do you think orthodes or intravitreal steroids will also have a role here, Carlos?
Yeah, that's an interesting point. I think the reason why I didn't consider that is because I thought I was giving a lot of steroids already systemically to this patient, but then you could ask, well, maybe it's because of of penetration. But we all know that choroidal lesions tend to be well supplied with the medication because of location, even though granulomas tend to be slightly different in behavior. I find that local approach in choroidal disease tends to be less useful than if I'm dealing with a retinal inflammatory disease. So retinal vascular diseases respond extremely well, but I don't find the local approach to be as good in controlling disease as for choroidal pathology as it is for retinal. So I didn't consider that in this patient at the time because of these factors. I thought we're already giving him a very large amount. It's choroidal, so he's getting steroids, and why he's not responding. But I did not consider the Ozurdex for the other reason of thinking it doesn't work. Clearly, maybe some of you have done it, and you may have a different experience. I'd be great to hear that.
Mm-hmm. Again, I think we have a good experience with Ozurdex in cases of infectious posterior uveitis, but in general to treat the macular edema in many cases when
Sure.
the infection is under control.
Sure.
And with systemic infectious systemic treatment with Ozurdex also.
Yeah.
Because I think all these cases with macular edema is a very challenging cases to treat the macular edema in those cases, no?
Sure. Yeah, that's fine. I agree.
Okay. So we can move to the other case, and probably we will have enough time to present the other case, Carlos. Now, Alex, you present the case,
or if you want, Carlos, you can.
Yes, I will.
Yes, or Carlos, you can present your second case.
Okay, I'll do very quickly then, so we don't take.
I think we have enough time.
Okay, let me just go quickly to case number 2, and this is a 50-year-old gentleman who presented to us with pain in the right eye, redness, and reduction in vision, and the symptoms started when he was traveling just a week before. And again, he gave me no previous ocular history, and the only systemic diagnosis that multiple sclerosis diagnosed 4 years prior to this event. He had a reduction of vision to 624 in his right eye. Vision in the left eye was 6.6. He had full color vision in both eyes, normal intraocular pressures, and a more intense inflammation anterior segment with granulomatous keratic precipitates, as you can see here in this image. The other eye was uninvolved. So this is what the right eye looked like, and I think you probably already have a very good clue of what's going on. And again, this case is again a challenge in terms of what to do. So we're dealing with an individual who presents delayed because he was abroad, he didn't get to be seen, then he returned to the UK and wasn't immediately seen, so there was a significant delay. And you can see the way he presented shows already a disease which is much more widespread, multifocal lesions involving his retina. So this is retinal pathology, different from the other case when it was choroidal pathology, and the other eye is uninvolved. This is just some autofluorescence images showing the areas of involvement. And again, interestingly here, an OCT scan of the affected eye showing that apart from the peripheral lesions that you saw, he also had a small amount of subfoveal detachment. And I'd like to mention that recently, and I mentioned that to Alex yesterday when we had a chat, I've seen a patient with the same diagnosis presenting with no obvious retinal involvement, but with a marked subretinal fluid in subfoveal detachment. So a very strange presentation in the early stages. This is a different case from the one I discussed with you yesterday, Alex. But so we saw this. So what is the differential diagnosis here? So these are the things you have to think about. And I'm sure that I believe all of you are already clicking your fingers on the first one, that what he had was an acute retinal necrosis. But there are other things that can potentially present with peripheral retinal lesions that might look necrotizing retinitis and will be confused with that. And you have to keep those in mind in your differential diagnosis. So what did we do for him? So we did run some tests looking for evidence of other infections. And we did take a sample from his aqueous and test for viral infections. And we, in view of the clinical presentation, made a clinical diagnosis of acute retinal necrosis and started him on the double dose of valcyclovir, 2 grams 3 times a day. And part of our protocol now is to put an injection of foscarnet at the time of presentation. So this is when he presented and he had this appearance, and this is when he came. This is a week later. His vision was reduced to 6/60. His color vision had crashed from being normal to no perception of color, and this is following that first intervention. You can see here the result of his PCR showed that this was varicella zoster related, and he had a marked increase in the subfoveal detachment with more fluid accumulating. So what we're going to do for this gentleman? So we gave him the intravitro antiviral. He's taking the dose of oral antiviral, which is corresponding, in terms of efficacy to intravenous antiviral. And what else can we do? So clearly, when you have someone in this situation, one other thing that can be done is the introduction of oral steroids, because clearly this eye is looking very inflamed. So he had more vitritis. Clearly his optic nerve seemed to have been involved because his color vision was down quite markedly and was potentially optic nerve related, even though the macula was also worse. So we could claim that would be the reason for that. And we can see here that with the introduction of the steroid plus something else, I decided, in view of the delay of his presentation and the advanced stage of the disease, that we would repeat his intravitreal foscarnet injection. And he had another intravitreal foscarnet injection in 2 occasions. He had intravenous injection number 2 and number 3, and that was coupled with the use of the oral steroids. So we can see that by doing that, we achieved a much better response with control of the retinal infection at the same time as controlling his inflammation, and consequently leading to improvement of his vision to the level of 6/9. So we can see the dramatic change from coming in with a vision that was reduced, then reducing further quite aggressively with more inflammation in the eye, and combining the approach of using a repeat intravitreal antiviral with the addition of steroids. We managed to turn it around and get him to improve his visual acuity to 6/9, with also improvement in his color vision. I think that was my short presentation. I made a specific, smaller this case because of and that with the help of Ilaria, of course, who was instrumental in putting this for me together. But it shows just this other, therapeutical situation that we have to deal with sometimes. Over back to you again, Alfredo. I think I finished within the 30 minutes of my time. Thank you.
Okay, perfect, Carlos. Los que queráis preguntar, tenéis aquí en la parte de abajo de la pantalla preguntas y respuestas que podéis enviar escritas. Yo creo que este caso es muy interesante porque plantea varias cosas. The first question, Carlos, is about, do you prefer always oral and intravitreal treatment? You don't use intravenous treatment in those cases with acute retinal necrosis?
Yes, we used to give a cyclovir 10 milligrams per kilogram 3 times a day for 10-14 days. That was our protocol many years ago. Mm-hmm. And then, of course, with the valcyclovir, double dose. So we can see it's 2 grams 3 times a day, not 1 gram 3 times a day. We achieve the same intraocular concentration. So we have not been using intravenous anymore. It avoids the admission to hospital of the patient, and we do just this double dose. And of course, we use the intravitreal injection at presentation. And like in this case, I felt that was important to repeat the injection because of how aggressive it had been. But we haven't been doing intravenous anymore. Our protocol is very much the one you see there.
Okay. And another question about the steroids in those cases of retinal necrosis, retinal viral retinitis. I think it's surprising. It's not the same, but now, for example, with the coronavirus, we see that the virus has one part is infectious with the virus, and the other part is this is an immune response. Correct. So probably is something similar here, no? Probably so. The virus is in the first part of the disease, has the very important role, and after this is the immunological aspect of the disease, no?
I think so, Alfredo. I think what we see in this case specifically, I think the larger the area of retinitis that you see, so the larger the area affected, you can see it was quite dramatic, the amount. You had also the lesions at the top. So the more infection you get, the more reaction you have in terms of inflammation, because you have more antigen. So there will be a very, very strong inflammatory response. If you get a very small lesion, you may very well get away with your antiviral treatment alone. So what are my indications for steroids? I don't think steroid is our standard protocol. We don't give steroids to all patients. But anybody who is getting an increased vitritis, which is the case here, is an indication of intense inflammation, or anyone who is developing optic nerve involvement, because you can get vasculitis affecting the optic nerve, and you look at the nerve, it looks like swollen. You need to intervene very quickly, because if they get an optic nerve, or more a vasculitis that they get, that they end up with an atrophic nerve and visual loss. So yes, I think you're right. Inflammation is a very important component. If it's mild and the disease is limited, I don't really introduce steroids. But in cases that are more aggressive, especially looking like this, we need to help, and steroids make a big difference.
Carlos, one question about the prophylaxis of retinal detachment. There is one question about the role of the early vitrectomy in those cases, or laser, or just to observe this case. What do you think about the risk that this patient has of retinal detachment?
I think that the larger the area of retinitis, the more vitritis, the more likely it is that the hole is going to be created somewhere. You are a vitreoretinal person, Alfredo, you know that well, and these are cases that you worry about. We don't believe that laser helps. I don't think we have evidence that laser treatment really stops a retinal detachment. Years ago, I published in the BJO an editorial when we compared the series that had been published comparing laser against no laser. But people were comparing pears and apples, they were not comparing the same thing. They were looking at patients that could be lasered because they didn't have enough vitritis, against patients who could not be lasered because they had too much vitritis. So you're not comparing the same thing. And the results show that the patients who had laser did better, but because they were better cases to start with. So it wasn't really the laser that made a difference. In terms of an early vitrectomy, that's a very good question. And I might revert that question to you, Alfredo, because as a VR person, we know that operating in this eyes in itself can create a retinal detachment. But we know as well that the vitreous, especially with an inflamed vitreous, it will potentially contract and then create many holes in this retina. So I'm interested in your views about this intervention.
Yes, I think in our experience in Barcelona is in the cases that they have extensive retinitis, 2 quadrants and extensive retinitis with a lot of inflammation, the vitritis that the patient has is impossible to do laser. So the risk of retinal detachment is very high. So in our experience, it's better to do surgery, vitrectomy, when the retina is attached. So in those cases, we prefer to do early vitrectomy, and I think our results are quite good. We perform vitrectomy and endolaser in 360 degrees to treat all the peripheral retina, and I think it's a very important point to do this surgery early, because if the retina detach, the visual results are very bad. Even if you attach the retina, the results are very bad. Yeah. So I think you can do early vitrectomy. You can perform in these cases to detach the posterior vitreous. That is easier if the retina is attached. And laser and probably the gas tamponade in those cases, I think the results are better.
And Alfredo, how early is early? How early do you go?
Early is 2 weeks, 3 weeks, when the vitreous is very haze. You have a big haze in the vitreous. You don't see good the peripheral of the retina. So I think it's 3 or 4 weeks when after the beginning of the retinal viral retinitis. I think if you wait more, probably the retinal will detach. And so I think in our experience, the retina detach in cases with extensive retinitis. More than 1 quadrant, 2 quadrants, 3 quadrants, I think they have more risk.
Okay, thank you.
And one question also for you, Carlos,
Yeah.
about how long and which dose do you maintain of oral valganciclovir in those cases?
Okay. So this level of 2 grams 3 times a day, which is our induction phase, which is equivalent to the intravenous treatment, that is maintained for about 2 weeks. Then the level is dropped to the standard. You can see here that the patient now in February was already down to 1 gram 3 times a day. So he was on 2 grams and then that was reduced. So once we go through the acute phase, we go down to 1 gram 3 times a day, and that level is maintained for at least 3 months. So if there is a reason to extend, we will. Someone who has a history of having had ARN already in the other eye, who presents now with ARN in the second eye, this individual may have to be maintained on antiviral for the rest of their lives. You know, we some have patients doing that because they do have a problem with controlling the herpes infection. We know that ARN is affecting individuals who are supposedly immunocompetent, but immunocompetent is a very broad term, and they do have a specific problem with the antigen, the lymphocyte response proliferation against viral antigens, especially the herpes viruses. So it means they are susceptible to developing this again. And sometimes some patients get actually meningitis, they can get encephalitis, they can get other complications. So if they show that behavior, they go for life. But in the standard case, 3 months, and then we decide to stop if all looks fine.
Carlos, is there any difference between the zoster and the simple herpes in those cases about the management of the patient?
Yeah, in general, zoster is more aggressive. Zoster tends to cause more problems. So we did a study years ago comparing the role of doing this PCR, because said, what do we need to do it? No, it's ARN. It doesn't depend on the virus to call ARN, but I think the behavior does change, and we tend to be more aggressive in terms of our approach with the varicella zoster. But in general terms, the protocol tends to be the same. But the concern about varicella zoster, as it is the case here, this is what we found in this individual, you may have to be more aggressive and eventually do what we've done in terms of going back into the eye and injecting the antiviral again. But in general terms, the protocol remains standard, it remains the same.
Thank you, Mas. There is another question about if you is frequent the nephrotoxicity in the cases with antiviral treatment, systemic antiviral treatment.
Is not frequent, but is a concern. So whenever you are treating patients with this level of antiviral therapy, and especially if it's going to be prolonged, your concern is going to be checking renal function on a regular basis. So we do have to worry about that. And we do have patients who have problems and we have to change the treatment, but it's not that common. So we see, of course, but we don't see it as frequently. So I think the important thing is you have to rescue the eye. This is a good approach, but keep in mind the potential side effects and do watch the renal function very closely.
Mm-hmm. Thank you very much, Carlos.
I'll stop sharing now so Alex can go and take over now. Thank you.
Thank you very much. And...
Vale, voy a compartir mi pantalla. Muy bien, vale. Yo creo que se ve, ¿no?
Sí, se ve perfecto, Alex.
Vale. Bueno, pues buenas noches a todos y muchas gracias por asistir a este webinar. Estoy contento porque antes he hecho un comentario de OCTs en casos de Vodkoyanagi arada y es el tema de mi charla, ¿no? Voy a empezar con una diapositiva que es de nuestro anterior webinar, del que celebramos antes de vacaciones y en el que Alfredo discutió y comentó el concepto de desprendimiento bacilar. Que el desprendimiento bacilar es esta imagen que tenéis aquí, es esta cavidad quística intrarretiniana que se ve muy frecuentemente en los casos de Vodkoyanagi arada y que se produce porque hay una separación, un split a nivel de la capa de los fotorreceptores, justamente a nivel de la capa de los mioides. Entonces, una de las cosas interesantes que se discutió en ese webinar es si estos desprendimientos bacilares realmente implican un peor pronóstico o una mala visión o bueno, que vaya peor el caso, ¿no? Y bueno, se dijo que no, que parece ser que, bueno, que se resuelven bien y con buena visión. Yo cuando estábamos comentando esto, pues me vino a la cabeza un caso que habíamos vivido en el hospital hacía ya un tiempo, un par de años, y que era este caso de una paciente joven con un vodka yanagi arada, es presento en las imágenes del ojo derecho, y que pues tenía un desprendimiento bacilar, como podéis ver en la imagen. Después del tratamiento, con pulsos de corticoides orales, inmunosupresión con acetaminofén, este es el aspecto de la lesión del OCT al mes. Y fijaros cómo realmente pues sí que se ven unas alteraciones en la retina externa, en la capa de los elipsoides, también la capa nuclear externa está algo alterada, y realmente la paciente incluso refería un cierto escotoma relativo. Entonces, de hecho, hay una publicación reciente del grupo de Visali Gupta y colaboradores de la India, en que ellos analizan el OCT de pacientes con vodka arada para valorar y analizar un poco el basilar y detachment, y ven que realmente estas granularidades o adelgazamientos de los elipsoides de la interdigitación es bastante frecuente, alrededor del 60%. O sea que realmente, pues bueno, el basilar detachment, sí, los pacientes probablemente recuperan visión, pero habría que ver qué grado de función visual pueden tener debido a estas alteraciones. Lo que he hecho es revisar casos que tenían la base de datos, casos de arada y de simpática, de oftalmia simpática, que como sabéis son enfermedades hermanas, y casos que hayan presentado anormalidades en la retina externa en la fase aguda tras el tratamiento. Entonces he encontrado un par de casos que yo pensaba que estas alteraciones de la retina externa estarían posiblemente relacionadas con un desprendimiento bacilar de debut, pero me he encontrado un hallazgo que no esperaba y que me gustaría compartir con todos vosotros. El primer caso es el de este chico de 34 años de Senegal, que tenía este ojo izquierdo. Este ojo sufrió un traumatismo hacía un año antes de la consulta, y además se complicó con una endoftalmitis. Y él consultaba, lógicamente, por el otro ojo, que tenía este aspecto, además de una muy mala visión, pues este desprendimiento exudativo masivo de la retina. Este es el angiograma con múltiples puntos de fuga, pooling del colorante, también hiperfluorescencia del disco óptico. Y bueno, no hay duda del diagnóstico, esto se trata de una oftalmia simpática. Esta es la OCT, en la cual se podían apreciar pliegues coroideos, el desprendimiento de retina, lo que podía ser un desprendimiento bacilar. Y el paciente pues, se trató con pulsos de corticoides, seguido de corticoides orales y ciclosporina. Esta es la evolución a la semana, con ya una buena evolución. Se está resolviendo el fluido subretiniano, la coroides ha disminuido las ondulaciones que se observaban, y al mes esta es la imagen. Realmente, pues bueno, no hay fluido, pero hay una alteración muy grave de la retina externa, con esta atrofia absoluta de la retina externa y algunas zonas de engrosamientos del epitelio pigmentario de la retina. A las 8 semanas, y cuando estábamos bajando los corticoides con una dosis de prednisona 7,5, presenta esta recidiva, una recidiva severa, con engrosamiento de la coroides, un desprendimiento exudativo, dudas de desprendimiento bacilar en esta zona, células en la cavidad vítrea, células en la coroides, y bueno, ponemos 4 pulsos de corticoides, se añade acetaminofén a la ciclosporina, y esta es la imagen al mes, que con una muy mala visión, que ya tenía de antes, con una atrofia muy importante de la retina externa, Y aquí podéis ver el mapa de grosores de la mácula, la autofluorescencia, con estas zonas de hiperautofluorescencia tenues, que es donde estaba el líquido subretiniano, y estas zonas de hiperautofluorescencia más intensas que se correlacionan con estas zonas de engrosamientos del epitelio pigmentario de la retina. Después vamos a volver a este caso, ya veréis por qué. Y el segundo caso que os quería comentar es el de esta chica joven, de 37 años, de Nicaragua. No tenía ningún antecedente relevante de interés y consulta por mala visión en su ojo izquierdo, por visión borrosa y dolor de cabeza. La visión en el ojo derecho era buena, estaba conservada, 20-32, y en el ojo izquierdo pues muy baja visión, 20-100. Había cierta celularidad en cámara anterior y la presión intraocular era de 12 milímetros de mercurio. Este es el aspecto de la OCT. Como pueden ver, en el ojo derecho había una pequeña cantidad de líquido subretiniano peripapilar, células en la cavidad vítrea. En el ojo izquierdo, un desprendimiento de retina exudativo más importante, engrosamiento coroideo, que no se ve aquí porque el scan no lo coge, y puntos hiperreflectivos. Estamos, lógicamente, ante un cuadro también bastante típico, un desprendimiento de retina exudativo bilateral con signos de inflamación intraocular. Pues pocas cosas pueden ser, pues fundamentalmente una, que es un embot Koyanagi-Harada. Se pone tratamiento con pulsos intravenosos de corticoides, se inician dosis de descendentes de esteroides orales y se inicia azatioprina. Esta es la evolución de los OCTs. Podéis ver el ojo derecho, que tenía muy poquito líquido al principio, cómo se resuelve enseguida, y el aspecto de la retina es muy bueno, con una agudeza visual de 20-20. Y esta es la evolución del ojo izquierdo, que también tarda un poquito más en resolverse el fluido subretiniano, se acaba resolviendo con peor visión. Y sí que me gustaría resaltar, esta es la imagen a las 6 semanas del ojo izquierdo, cómo se ha producido a este nivel una atrofia absoluta de la retina externa y unos engrosamientos focales del epitelio pigmentario de la retina. Aquí también una disrupción de los elipsoides. Esta es la autofluorescencia, que muestra zonas de hiperautofluorescencia tenue donde había estado líquido subretiniano, y también estas lesiones focales más intensas de hiperautofluorescencia que se correlacionan con los focos de hipertrofia de engrosamiento del epitelio pigmentario de la retina. Entonces, analizando con detalle este OCT, bueno, aquí tenemos esta porción de la retina en la que podemos delinear perfectamente las capas nucleares, la capa de células ganglionares, la nuclear interna y la nuclear externa. Pero si cogemos la otra porción, veremos que si intentamos delinear estas capas, la nuclear externa, pues no somos capaces. Realmente lo que estamos viendo es una hiperreflectividad donde tendría que haber una hiporreflectividad correspondiente a la capa nuclear externa. Y volviendo al caso de simpática que hemos presentado al principio, me gustaría que se fijasen que realmente lo que estaba ocurriendo en la OCT de este paciente al principio es muy parecido, esta hiperreflectividad en la nuclear externa, muy parecido a lo que está ocurriendo con el actual caso de Koyanagi-Harada. Y aquí encima, arriba, tenéis una imagen de un OCT normal. Fíjense que aquí hay una hiperreflectividad que no tendría que estar. Y la evolución, además, tanto de la oftalmología simpática como del Koyanagi-Harada, pues son iguales. Es decir, una atrofia absoluta de la retina externa con zonas de engrosamiento del epitelio pigmentario de la retina en los dos casos, como podéis ver en las imágenes. Por lo tanto, yo pienso que realmente esta atrofia que he visto, estas alteraciones tan severas de la retina externa, no son tanto por el Basel y Detachment, sino por esta anomalía, esta hiperreflectividad de la retina externa que se observa en las imágenes. La hiperreflectividad de las capas de la retina en OCT en el contexto de uveitis está descrita, la podemos ver en la retina interna en casos de retinitis o en casos de algún problema isquémico como la toxo ocular o vasculitis retinianas. En la retina central por una alteración isquémica, como ocurre en la maculopatía medial aguda paracentral o PAM. Y en la retina externa también podemos ver a veces estas hiperreflectividades en casos de alteración isquémica o inflamación inflamación. Por ejemplo, en casos de una neuroretinopatía macular aguda o en casos de serpiginosa o serpiginoide y en casos de placoide, de epitelopatía placoide posterior multifocal aguda. Aquí tienen algunas imágenes de hiperreflectividades en la retina interna, sobre todo la toxoplasmosis, aunque a veces puede ser incluso de toda la retina. En el caso de Behçet, aquí tiene esta imagen un foco de retinitis, que no se debe confundir con un vaso porque los vasos tienen sombra posterior. Esto es un foco de retinitis que se resolvió con el tratamiento. Aquí hiperreflectividad en las capas más medias, en el caso de una PAM. Hiperreflectividades en la zona de la retina externa, con un caso de epitelopatía placoide posterior multifocal aguda. Hiperreflectividad en las capas externas en los casos de serpiginoide e hiperreflectividad también en las capas externas en casos de neuroretinopatía macular aguda. Yo, por lo que me he podido revisar, tanto en la literatura como en los casos que hemos controlado en el servicio de Arada y de Simpática, no hemos podido observar esta hiperreflectividad tan intensa de la capa nuclear externa. ¿Cuál podría ser la patogenia? Y aquí entramos ya en el terreno de las hipótesis. Pues bueno, se nos puede ocurrir que a lo mejor una inflamación coroidea muy, muy importante puede provocar una liberación de una cantidad muy grande de productos inflamatorios que pueden llegar a la capa nuclear externa y dañarla, o que esta inflamación tan importante puede comprometer la irrigación de la retina externa. Probablemente hay una predisposición personal, porque realmente estas alteraciones, esta hiperreflectividad no ocurre o es poco frecuente, al menos en nuestra experiencia. Probablemente hay una predisposición personal, genética. Y la evolución, bueno, hemos visto que la evolución en estos dos casos es hacia la atrofia de la nuclear externa, desaparece la membrana orbitante externa, desaparecen los elipsoides y hay zonas de atrofia y zonas de hipertrofia focal del epitelio pigmentario de la retina. Esta alteración en concreto de las zonas de hipertrofia del epitelio pigmentario de la retina han sido descritas ya hace unos años por el grupo de Vasconcelos Santos, el grupo de Nursing Rao, pero eran casos de pacientes con BOT-COINAGRA más crónicos. Pues fíjense que las imágenes tanto de la autofluorescencia como el infrarrojo como la OCT son exactamente iguales que la de nuestros casos. Y realmente, pues la visión, la función visual está muy afectada. En el caso de la simpática, pues había una afectación muy importante porque afectaba justo a la zona subfoveal. Y en el caso de la que hemos visto, pues la paciente conserva una buena visión porque el centro foveal no está afectado. Y bueno, si recogemos más casos y tenemos la oportunidad de hacer un estudio con una N mayor, pues probablemente veamos que estas lesiones, esta hiperreflectividad, pueda ser un biomarcador de pronóstico visual. Y nada más, esto es todo lo que quería compartir con vosotros. No sé si habéis tenido la oportunidad de observar estos signos, Alfredo, Carlos.
Lo que está pasando ahora, tú también te estás haciendo un experto en el desprendimiento de la capa bacilar también.
Sí, sí, sí. Es un tema que me interesa mucho.
Lo que pasa con todo esto, una vez que ves todas estas cosas tan novedosas, es que lo que haces es revisar tus casos.
Claro, efectivamente.
Y cosas que a lo mejor no entendías,
Efectivamente.
dices, es verdad esto que está descrito, ¿no? Y cosas que habían pasado tal, al mirarlo, pues, y todo esto que tú comentas, yo no me he fijado, pero realmente revisaremos nuestros casos para fijarnos si realmente hay este signo que tú comentas.
El desprendimiento bacilar sí que es frecuente, porque mirando incluso CTs del stratus de pacientes antiguos, ostras, lo ves, ¿eh? Y en la serie esta del grupo de Gupta, revisan alrededor de 100 pacientes y tienen, pues no sé si un 95% de ojos tienen desprendimiento bacilar.
Hay una pregunta que no sé si Carlos también está conectado.
Yo estoy acá.
La imagen esta que tú comentas, que es hipertrofia del epitelio pigmentado de la retina, yo no tengo tan claro que no sea engrosamiento de los fotorreceptores. O sea, no tengo tan claro que no sea que los fotorreceptores están, la capa de los fotorreceptores está alterada y los fotorreceptores están como engrosados y es más que del epitelio pigmentado, yo creo que sería de capas más
Puede ser.
externas.
¿Tú te refieres ya cuando se resuelve? Cuando
Se resuelve y ves que el paciente no ve, y se ve toda esta imagen irregular que de alguna forma tú puedes decir es hipertrofia. Yo no tengo tampoco claro que no sea fibrosis más que procesamiento, ¿no?
Puede ser algún foco de fibrosis incipiente. Esto también, porque la fibrosis además en la autofluorescencia te da hiperautofluorescencia. Yo creo que los fotorreceptores están volados, o sea, no hay nuclear externa, no hay elipsoides, y puede ser que sea cierto grado de fibrosis, efectivamente. De hecho, en la serie de Vasconcelos del año 2010 de publicada en Retina, habían algunos tractos que sugerían fibrosis, y la señal de autofluorescencia es hiperauto igual, y de la misma intensidad. Pueden ser pequeños focos de fibrosis. Lo que pasa es que es al mes del tratamiento. Normalmente la fibrosis, yo los casos que me he revisado, pues normalmente tarda un poco más en aparecer, pero bueno, no sé, es un buen punto.
Alex, I remember in the past when VKH was not treated aggressively enough, and it took a long time to control the detachment. We saw so many cases with very dense subretinal fibrotic bands. And those bands were actually hyperpigmented many times. And that would be sometimes the reason why they lost vision. So clearly, the longer the inflammatory event, the more aggressive it is, the more likely that fibrosis will develop. And we are not seeing as much anymore because we are very aggressive in treating these patients. So we are reducing that element quite significantly.
Yeah, I think that's true. And we are not seeing also sunset glow, for example, because, we, at least in our case, we put them on immunosuppressive from the beginning, and we don't see any more sunset glow, because sunset glow at last is in chronic inflammation of the choroid. So
sure.
if you don't treat with immunosuppressive, but of course you won't have retinal detachment, but you will have a subclinic inflammation of the choroid, and you will have depigmentation of the fundus, more fibrosis and lesions, atrophy, etc.
Absolutely. This is the under-treatment of every choroidal disease can produce that. Even look at birdshot, which is not an acute disease in any way. Birdshots are very chronic, low-grade inflammation most of the times. But if you do not treat the choroid adequately, you end up with significant RPE loss and photoreceptor loss in the course of the disease. So it is really important that the choroid has to be really well controlled. And that's the reason why the treatment of this disease is sympathetic. VKH has to be aggressive and prolonged. So you make sure that the choroid just shuts down completely the inflammation. Otherwise, you think you're winning because the detachments disappear, but you're actually losing in the long run because you're still exposing the outer retina to inflammation. Yeah.
And I think in my experience, sympathetic is a worse disease comparing with VKH. I think the cases with sympathetic, and probably this is a very, very conflicting or very discussing point, but I prefer in the cases with sympathetic to introduce very early the biologic, the adalimumab, because I think you change the evolution of the disease. Probably if you follow the cases with sympathetic for a long time, the problem is always the eye is with inflammation. You have to treat the patients chronically with immunosuppression agents. But the cases that you introduce with steroids, with intravenous steroids, in the acute phase, you introduce very early the adalimumab, probably the results are, in my experience, are better. But this is a point that we can discuss a lot because it's the top-down approach that is similar to other immune diseases that I think in the special cases of uveitis, I think has a role.
Yeah, no, I think you're right. I think that the sympathetic and VKH are diseases that can behave either very well or very badly. And the very early recognition, very aggressive treatment right from the start, and with the introduction of immunosuppression, either with biologics or other forms of immunosuppression, is really essential to reduce the damage long term. So I think it's a very strong point for people who are listening now to really think about this, because they can respond very well to steroids, but in the long run, they do badly if just steroids are used.
Okay, yeah. And also in the last years, we have a lot of information from the OCT, OCTA, wide field image. I think has changed a lot the management of the posterior intermediate and vasculitis, because you have a lot of information about the amount of the inflammation, the localization of the inflammation. So I think it's as you show and Alex also show in the cases, you have many ideas about the evolution of the patient, why this patient has a very bad evolution. Or I think you have a lot of information in the image, in the new image technology that is very important for the management of the patients.
And I think Alex showed a very important case there, comparing the images of the different etiologies. And you can see like APN PPE, which is also a inner choroidal pathology, you don't get this very intense inflammatory response. So if you look at the outer retina, you do get involvement of the ellipsoid zone. It gets abnormal, then dysfunctional. And interestingly, in some patients, there is good recovery of that, because what you see is not destruction, it's just abnormality of the way it's aligned. But you don't get the same outer retina, the inner retinal involvement, because the inflammation is not as severe. So it remains more limited in what it can do.
Okay. Thank you, Carlos, for participating in our webinar and to share with us your experience in uveitis. And I think probably you will be able to come the next year to our meeting in Spain, to our society, and it's an honor for us that you would participate in the meeting. Okay.
Muchas gracias, Alfredo, muchas gracias, Alex, y muchas gracias a todos. Un placer muy grande estar con todos. Si COVID nos permite, sí, te vengo. Okay.
Muy bien.
Gracias.
Buenas noches a todos.
Muchas gracias.
Hasta luego. Hasta luego.
Adiós.
Adiós.